In the previous module, we studied how the female genital tract develops from the paired Müllerian ducts, the urogenital sinus, and the surrounding embryonic tissues. The Müllerian ducts normally undergo three essential processes: formation, fusion, and resorption of the intervening septum. The vagina also requires proper joining and canalization of its developmental components. Most congenital anomalies of the uterus, cervix, and vagina can therefore be understood by identifying which developmental process has failed. A failure of formation prevents part or all of a structure from developing. A failure of fusion prevents the paired Müllerian ducts from joining normally. A failure of septal resorption leaves a partition within the uterine cavity. A failure of vaginal canalization produces an obstructed or absent vaginal passage. Once the failed developmental step is identified, the resulting anatomy becomes much easier to understand. Let us begin with failure of Müllerian duct formation. The first group of congenital anomalies results from failure of Müllerian duct formation. Normally, one Müllerian duct develops on each side of the embryo during the 6th week of development. These paired ducts grow downward along the mesonephric ducts before eventually contributing to the formation of the uterine tubes, uterus, cervix, and the upper portion of the vagina. If the normal development of one or both Müllerian ducts is interrupted during this early stage, the structures derived from those ducts either fail to develop completely or develop only partially. The severity of the anomaly depends on whether one duct or both ducts are affected. Let us first consider failure of a single Müllerian duct. If one Müllerian duct develops normally while the opposite duct fails to develop or elongate, a unicornuate uterus is formed. Instead of a normal uterus with two symmetrical halves, only one side develops completely. As a result, the uterus is smaller than normal and contains a single well-developed uterine horn. On the opposite side, a rudimentary horn may be present. This rudimentary horn may contain only fibrous tissue, or it may contain a functional endometrial cavity. If a functional cavity is present but has no communication with the main uterine cavity, menstrual blood cannot drain normally. Blood gradually accumulates within the rudimentary horn, producing hematometra. Patients commonly present with progressive cyclic pelvic pain beginning after menarche. In some cases, fertilization may occur within a rudimentary horn. Although rare, this represents a life-threatening condition because the poorly developed muscular wall cannot support a growing pregnancy. Rupture of the rudimentary horn may result in severe intra-abdominal hemorrhage. Pregnancy within the normal unicornuate uterus is possible. However, because the uterine cavity is smaller and asymmetric, reproductive outcomes are often affected. Patients have an increased risk of miscarriage, fetal growth restriction, malpresentation, and preterm delivery. The diagnosis is usually established using three-dimensional ultrasound or magnetic resonance imaging, which demonstrate the single uterine horn and identify the presence or absence of a rudimentary horn. When a non-communicating rudimentary horn produces symptoms or contains functional endometrium, surgical excision is generally recommended to prevent future complications. Failure of both Müllerian ducts to develop results in bilateral Müllerian agenesis. Instead of forming the uterus, cervix, and upper vagina, these structures are absent or severely underdeveloped. This developmental defect forms the embryological basis of Mayer-Rokitansky-Kuster-Hauser syndrome, commonly known as MRKH syndrome. Because MRKH syndrome has unique clinical features, genetic associations, and important systemic abnormalities, we will examine it separately in the next section before continuing with the remaining Müllerian duct anomalies. Bilateral Müllerian agenesis is most commonly encountered clinically as Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH syndrome. MRKH syndrome results from failure of normal development of both Müllerian ducts during early embryogenesis. As a consequence, the uterus and the upper two-thirds of the vagina are absent or severely underdeveloped. Despite this, the ovaries are usually completely normal. This is because the ovaries develop from the gonadal ridges and primordial germ cells rather than from the Müllerian ducts. The external genitalia also develop normally because they arise from different embryological structures. Therefore, affected individuals have a normal female appearance, normal secondary sexual characteristics, and a normal female karyotype of 46XX. The condition usually becomes apparent during adolescence. Most patients seek medical attention because they have primary amenorrhea, despite normal breast development and normal pubertal progression. Since ovarian function is preserved, normal levels of estrogen are produced. As a result, puberty proceeds normally, even though menstruation does not occur. MRKH syndrome is broadly divided into two forms. Type I, also called the isolated form, is confined to abnormalities of the reproductive tract. Only the uterus and upper vagina are affected. Type 2, sometimes referred to as the Merck's association, includes additional congenital abnormalities involving other organ systems. These commonly involve the kidneys and the axial skeleton. Renal abnormalities are particularly frequent and may include unilateral renal agenesis, ectopic kidneys, horseshoe kidneys, or collecting system anomalies. Skeletal abnormalities most often involve the cervical or thoracic vertebrae. For this reason, every patient diagnosed with MRKH syndrome should undergo evaluation for associated congenital abnormalities. The diagnosis is usually suspected clinically and confirmed with imaging. Pelvic ultrasound may demonstrate the absence of the uterus. However, magnetic resonance imaging provides a much more detailed assessment of the pelvic anatomy. MRI confirms the absence or hypoplasia of the uterus, evaluates the upper vagina, demonstrates normal ovaries, and identifies associated abnormalities of the urinary tract. Although several genes have been implicated in MRKH syndrome, the exact cause remains incompletely understood. Mutations involving genes such as WNT4, LHX1, HNF1B, and several other candidate genes have been identified in some patients. However, these explain only a minority of cases. Current evidence suggests that MRKH syndrome is genetically heterogeneous and probably results from multiple interacting genetic and developmental factors rather than a single causative mutation. Management is directed toward restoring normal sexual function and providing psychological support. Because functional ovaries are present, oocyte production remains normal. However, natural pregnancy is not possible in the absence of a functional uterus. Options for fertility include assisted reproductive techniques with a gestational carrier. Uterine transplantation has also emerged as a developing therapeutic option in selected patients, although it remains highly specialized. MRKH syndrome illustrates an important embryological principle. Failure of early Müllerian duct development affects the organs derived from those ducts alone. Structures that arise from different embryological origins, such as the ovaries and external genitalia, remain unaffected. Understanding this distinction explains the characteristic clinical presentation of the syndrome and provides the foundation for understanding the associated congenital abnormalities that we will discuss next. The next group of congenital anomalies results from failure of Müllerian duct fusion. In the previous module, we learned that the two Müllerian ducts initially develop as separate structures. As they descend into the pelvis, they gradually move toward each other. Their caudal portions then fuse in the midline to form the uterovaginal primordium, which later develops into the uterus, cervix, and upper vagina. This fusion normally begins near the caudal end of the ducts and progresses upward. If this process is interrupted, the uterus cannot develop as a single midline organ. Instead, the degree of separation depends on how much fusion has failed. The most complete form of fusion failure is known as uterus Didelphys. In this condition, the two Müllerian ducts develop normally but never fuse with one another. As a result, each duct forms its own uterus. The patient, therefore, has two completely separate uterine cavities, each with its own cervix. Because the lower portions of the ducts also remain separated, a longitudinal vaginal septum is frequently present. The ovaries remain normal because they do not arise from the Müllerian ducts. Many women with uterus Didelphys remain completely asymptomatic, and the anomaly is discovered incidentally during pelvic imaging or pregnancy. Others may present with dyspareunia, difficulty using tampons, or obstruction of one vaginal canal when a longitudinal septum is present. Although fertility is often preserved, pregnancy outcomes are not completely normal. There is an increased risk of miscarriage, preterm delivery, fetal malpresentation, and cesarean section. Diagnosis is usually established using three-dimensional ultrasonography or magnetic resonance imaging, both of which clearly demonstrate two separate uterine bodies and two distinct cervices. If fusion occurs only partially, the resulting anomaly is a bicornuate uterus. Here, the lower portions of the Müllerian ducts fuse normally, but the upper portions remain partially separated. Instead of two completely independent uteri, a single uterus develops with two uterine horns. Externally, the fundus shows a deep central cleft because complete fusion never occurred. The cervix may remain single or may be duplicated depending on the extent of fusion. This external fundal indentation is the key anatomical feature that distinguishes a bicornuate uterus from a septate uterus, which we will study next. Like uterus Didelphys, many women with a bicornuate uterus are able to conceive naturally. However, the abnormal shape of the uterine cavity reduces the available space for fetal growth and alters normal uterine mechanics. Consequently, pregnancies are associated with an increased risk of miscarriage, malpresentation, preterm labor, and occasionally fetal growth restriction. Recognition of these anomalies depends on understanding the normal process of Müllerian duct fusion. When fusion fails completely, two separate uteri develop. When fusion fails only partially, one uterus with two horns is formed. The severity of the anomaly therefore reflects the degree of failed embryological fusion. The final major group of Müllerian anomalies results from failure of septal resorption. Unlike the previous anomalies, the Müllerian ducts develop normally. They also fuse normally in the midline. However, one important developmental step still remains. After fusion, the newly formed uterovaginal canal is initially divided internally by a central partition. This partition is called the Müllerian septum. During normal embryonic development, the septum gradually disappears through a process known as septal resorption. Once resorption is complete, a single uterine cavity is formed. If this process fails, a septate uterus develops. The extent of the septum may vary considerably. In some patients, only the upper portion of the uterine cavity is divided. This is known as a partial septate uterus. In others, the septum extends almost to the internal cervical os or even into the cervix and vagina. This is referred to as a complete septate uterus. Although the uterine cavity is divided internally, the external surface of the uterus develops normally because fusion has already occurred successfully. This is the most important feature that distinguishes a septate uterus from a bicornuate uterus. In a bicornuate uterus, fusion fails. Therefore, the outer contour of the fundus shows a deep cleft. In a septate uterus, fusion is complete. Only the internal partition persists. The external fundal contour therefore remains normal or nearly normal. This distinction is clinically important because the two anomalies are managed differently. A septate uterus is the most common congenital uterine anomaly and is also one of the anomalies most strongly associated with reproductive failure. The persistent septum often has a relatively poor blood supply compared with the normal uterine wall. If implantation occurs on the septum, placental development may be inadequate. As a result, patients have an increased risk of recurrent first trimester miscarriage. They may also experience infertility, second trimester pregnancy loss, preterm birth, and fetal malpresentation. Diagnosis relies primarily on three-dimensional ultrasonography and magnetic resonance imaging, both of which demonstrate a normal external uterine contour together with an internal septum. Hysteroscopy can directly visualize the septum and also allows treatment during the same procedure. When recurrent pregnancy loss or infertility is attributed to a septate uterus, the septum can be removed by hysteroscopic septal resection. Because the procedure restores a single uterine cavity while preserving the normal outer uterine wall, reproductive outcomes often improve significantly. Not every minor indentation of the uterine cavity represents a pathological septum. Some women have a shallow indentation at the fundus known as an arcuate uterus. This represents only a mild variation in uterine shape, resulting from minimal incomplete septal resorption. Unlike a true septate uterus, an arcuate uterus is generally considered a normal anatomical variant and usually has little or no effect on fertility or pregnancy outcomes. The developmental sequence is therefore straightforward. If the Müllerian ducts fail to form, formation defects occur. If they fail to fuse, fusion defects occur. If they fuse normally but fail to remove the intervening septum, septal resorption defects occur. With these three embryological mechanisms complete, we can now move beyond the uterus to study congenital anomalies of the vagina, where the developmental errors involve fusion with the urogenital sinus and canalization rather than Müllerian duct fusion alone. Until now, we have focused primarily on developmental abnormalities of the uterus. The vagina, however, has a more complex embryological origin. As discussed in the previous module, the upper one-third of the vagina develops from the fused Müllerian ducts, while the lower two-thirds develop from the sinovaginal bulbs, which arise from the urogenital sinus. For a normal vaginal canal to form, these embryological components must not only develop correctly, but also fuse and subsequently undergo canalization. Failure of any of these developmental events gives rise to congenital vaginal anomalies. One of the most common is the longitudinal vaginal septum. This anomaly usually results from incomplete fusion of the Müllerian ducts. Instead of forming a single vaginal lumen, a vertical partition persists within the vagina, partially or completely dividing it into two channels. A longitudinal vaginal septum is frequently associated with uterus Didelphys because both anomalies arise from failure of Müllerian duct fusion. Some women remain completely asymptomatic. Others may experience dyspareunia, difficulty with tampon insertion, or obstruction of one vaginal canal. The diagnosis is usually established during pelvic examination or confirmed by imaging. Symptomatic septa can be treated by surgical excision with excellent outcomes. A different developmental error produces a transverse vaginal septum. Unlike a longitudinal septum, this anomaly results from failure of fusion or canalization between the Müllerian-derived upper vagina and the urogenital sinus-derived lower vagina. Instead of a vertical partition, a horizontal wall forms across the vaginal canal. The septum may occur at the upper, middle, or lower portion of the vagina and may be complete or contain a small opening. If the septum is complete, menstrual blood cannot pass through the vaginal canal after puberty. Instead, blood accumulates above the obstruction, producing hematocolpos. If the uterus also becomes distended with retained blood, hematometra develops. Patients typically present shortly after menarche with primary amenorrhea, cyclic pelvic pain, and an enlarging pelvic mass. Imaging studies, particularly magnetic resonance imaging, accurately define the location and thickness of the septum before surgical correction. Another important congenital anomaly is the imperforate hymen. Unlike the previous abnormalities, this condition does not involve the Müllerian ducts. Instead, it results from failure of the inferior portion of the vaginal plate to perforate during late fetal development. Because the hymenal membrane remains intact, the vaginal opening is completely obstructed. During infancy, the condition may remain unnoticed. However, after menarche, menstrual blood accumulates within the vagina, producing hematocolpos, and may subsequently distend the uterus to produce hematometra. Clinically, patients present with primary amenorrhea, cyclic pelvic pain, lower abdominal swelling, and sometimes urinary retention due to compression of the bladder. On physical examination, a tense bluish bulging hymenal membrane may be visible at the vaginal introitus. Treatment is straightforward and consists of surgical hymenotomy or hymenectomy, which establishes normal menstrual outflow and relieves the obstruction. Although these congenital anomalies differ anatomically, they all illustrate the same embryological principle. Normal vaginal development depends upon successful fusion of embryological structures and complete canalization of the developing vaginal tract. Failure of these processes results in persistent septa or distal obstruction, leading to impaired menstrual outflow and characteristic clinical presentations. With this, we have completed the major congenital anomalies of the female genital tract. In the final section, we will integrate these developmental abnormalities into a single embryological framework that makes them easier to understand, remember, and apply in clinical practice. Throughout this module, we have studied how a relatively small number of embryological events give rise to the normal female genital tract. More importantly, we have seen that nearly every congenital anomaly can be understood by identifying which developmental step failed. Rather than memorizing individual abnormalities, it is far more useful to understand the underlying embryological sequence. The first critical step is formation of the Müllerian ducts. If one duct fails to develop, a unicornuate uterus is produced. If both ducts fail to develop, bilateral Müllerian agenesis occurs, giving rise to Mayer-Rokitansky-Kuster-Hauser syndrome, in which the uterus and upper vagina are absent, while the ovaries and external genitalia remain normal because of their different embryological origins. The second developmental step is fusion of the Müllerian ducts. Complete failure of fusion results in uterus Didelphys, producing two separate uterine cavities, two cervices, and frequently a longitudinal vaginal septum. Partial failure of fusion produces a bicornuate uterus, in which the uterus develops as a single organ with two uterine horns separated by a deep external fundal cleft. The third developmental step is resorption of the intervening Müllerian septum. When fusion occurs normally but the septum fails to disappear, a septate uterus develops. Unlike fusion defects, the external contour of the uterus remains normal because the developmental error lies entirely within the uterine cavity. Finally, normal vaginal development depends upon fusion between the Müllerian-derived upper vagina and the urogenital sinus-derived lower vagina, followed by complete canalization of the vaginal plate. Failure of these processes results in congenital vaginal anomalies such as longitudinal vaginal septum, transverse vaginal septum, and imperforate hymen, each producing characteristic patterns of outflow obstruction and clinical presentation. Although these anomalies differ anatomically, they all arise from disruption of a limited number of embryological events. This is why embryology is far more than a description of fetal development. It provides the developmental blueprint that explains congenital malformations, guides radiological interpretation, predicts associated abnormalities, and forms the foundation for appropriate clinical management. By approaching these conditions through their embryological mechanisms, complex congenital anomalies become logical consequences of specific developmental failures rather than isolated facts to be memorized. In the next module, we will continue building this developmental framework by examining the molecular regulation of female genital tract development, including the genetic and signaling pathways that control Müllerian duct formation, differentiation, and sexual development. Understanding these mechanisms provides the link between normal embryology, congenital anomalies, and many developmental disorders encountered in both pathology and clinical practice.